Welcome, and thank you so much for watching this webcast. My name is Kerry, and I'm a licensed clinical social worker and the psychosocial services manager at the Patrick Dempsey Center for Cancer Hope and Healing in Lewiston, Maine. We are a center that provides free support, education, and wellness services to people impacted by cancer. I've been very, very fortunate to have been able to work in oncology and hospice care settings since 1995. And I was so incredibly deeply honored to receive the American Cancer Society's Quality in Cancer Care Award at the recent Association of Oncology Social Work Conference in Tampa, Florida, where I first delivered this talk. And I'm going to note for you that the location was in Tampa and we were harborside, and so you'll notice that there's a bit of an ocean theme in my slides. I've always felt like getting to do this work in oncology was like winning the career lottery. We all know that this isn't easy work, but it's hard to imagine anything more fulfilling. And I found that my colleagues on oncology, not only my beloved oncology social work colleagues, but also the chaplains, the nurses, the doctors, the oncology dietitians, the oncology massage therapists. These are some of the wisest, most passionate, caring, smart, funny, and deeply, deeply kind people that I know. And I am just so inspired by and grateful for the people who make up both the organizations of the American Cancer Society and the Association of Oncology Social Work. And I thank you from the bottom of my heart for all that you have and will continue to teach me. Our greatest teachers in this field, of course, are our clients, and I felt especially privileged to get to learn from people who are living with advanced illness in particular. So the focus of my talk today relates to our work with this population, including some of the ways in which working with advanced cancer patients can both enhance and help us maintain our own professional resiliency. And although the talk was geared toward oncology social workers and psychologists and chaplains, I believe that other professionals within the field may find nuggets that are useful. During this talk, I'll cover some of the common psychosocial and spiritual concerns of people living with advanced cancer and describe 3 clinical interventions to help our clients cope with the rough seas of advancing illness: mindfulness, logotherapy, and meaning-centered psychotherapy. I'll also talk about how these same interventions can help oncology social workers and other oncology professionals to cope with the stressors inherent in our work and can reduce the likelihood of burnout and compassion fatigue. When a person is living with advanced illness, the experience may often feel like losing one's mooring, like being cast off into vast and unknown waters. The writer Andre Gide reminds us that we cannot discover new lands without losing sight of the shore for a long time. And we know that this losing sight of the shore can be simultaneously terrifying and liberating. We'll begin by talking about the parts that initially feel terrifying. Oncology professionals are very familiar with the stormy seas that our clients face as illness progresses. In addition to the physical and financial challenges, psychosocial and existential or spiritual concerns are nearly universal among those living with advanced illness. So I'd like to start out with just a quick review of some of these concerns before we delve into interventions. Fears. Most patients with advanced illness struggle with some fear, often about pain, about becoming a burden to their loved ones, about the dying process, about what happens after they die, about what will happen to their family after they die. Tara Brach, who is a psychotherapist and a Buddhist meditation teacher, told a true story once in one of her Dharma talks about a boy who was feeling frightened during a nighttime thunderstorm. The thunder would roll, the lightning would crack, and the young boy would call out to his parents, who would take turns going into his room to comfort him. On about the fourth trip in, his father, who was perhaps growing a little bit weary, reminded him, "Son, there's no need to be afraid. You're never alone. God is always with you." His father was a minister. His son looks up at Dad, kind of rolls his eyes and said, "Well, I know that, Dad, but sometimes I just need to be with somebody who has their skin on." And this story gave me a good chuckle, but it has also really touched me and stayed with me because it really points to such a basic human need for presence when we're feeling frightened. Yet so many people with advanced cancer are left alone with their fears because their loved ones and their healthcare providers, for a variety of reasons, fail to ask. So this is when we as clinicians and our friends in pastoral care can really step up, be brave, and invite the patient to share their fears so that they don't have to be alone with them, so that they have a caring presence. And there are many ways to open up the conversation. We start by establishing a sense of safety and trust and welcome, conveying our intention and our ability to be present. We may then ask questions like, what frightens you most about what is happening to you now? What are your fears and worries about what lies ahead with your illness? What situations do you worry might become overwhelming for people who you love and rely on? Do you have any worries about death or about what the dying process might be like? And there may be times when it's appropriate to offer to bring others into the conversation, such as the patient's loved ones, their physician, the palliative care team, the chaplain or other clergy member. And it's often the role of the oncology social worker to help facilitate conversations within a family about managing the shifts in roles and responsibilities as an illness progresses, and to provide education about and referrals to hospice and home care, palliative care, and other programs. And these are opportunities for us to invite family members to give voice to their fears and concerns as well, and to offer them our support. We also need to recognize that people often feel very vulnerable and exposed when they've shared their fears with someone else. So it's important to help our clients process the experience of talking about their fears afterward and to offer acknowledgement to them for their courage in doing so. We also know that as cancer progresses, patients have to confront many, many changes and losses along the way, both current ones and anticipated ones. There's the loss of the illusion of control, and it's very important to note that word illusion because that's what it is. And this loss hits both at the time of initial diagnosis and then again, and often even harder, at times of recurrence or disease progression. And perhaps there's always both loss and gain when we learn that we aren't in control of everything. But initially, the loss of that illusion and the familiarity of that is often terrifying and results in grief. The physical losses that people encounter along the way are often unrecognized or are minimized, especially when, say, a body part is initially removed with the goal of cure or of prolonging life. And sometimes people feel ashamed or judged by others or by themselves for grieving the loss of a body part. But that grief is very real, and we can be helpful by simply acknowledging it. Some of my clients have found it helpful to write a goodbye letter or an obituary or even a funeral service for a lost body part as part of a grief ritual. And we also know that people struggle with the loss of capacity, energy, and health in general. How many times have you heard patients say, "I'm just so sick and tired of being sick and tired"? There's the loss of a sense of purpose, and this is often related to shifts in identity and role functioning, and is particularly endemic in a culture like ours, where what we do often matters more or appears to matter more than who we are. So when someone is highly identified with roles that they play, for example, as a professional, as an involved grandparent, as an active church member, as an active volunteer, as a weekend athlete, they often feel a great sense of loss when those roles are diminished or changed significantly by illness. And we'll be talking about this type of loss and ways to respond to it in greater depth when we discuss logotherapy. There's also the loss of opportunity to complete unfinished business, unfulfilled dreams and goals, unresolved relationships, etc. And this too is an area where we as clinicians have much to offer our clients. And we'll be talking about interventions that can be applicable here. Lastly, there's the impending loss of life itself and everything that it contains that our clients are dealing with. And as we know, the normal response to these and any other type of loss is grief. But we live in a culture that doesn't always know what to do with grief, that wants us to hurry through it, get over it, and move on. Or at the very least, to put on a happy face so that others can be more comfortable. So as clinicians and just as human beings, really, we offer so much by providing a compassionate presence and witness to other people's grief processes when we aren't trying to fix or cure them, but simply to accompany them. Existential and spiritual concerns also abound, and research has shown that a strong sense of spirituality, whether it's rooted in religion or defined more broadly than that, can aid coping and enhance a sense of well-being for patients with advanced illness. And we'll be talking more about that shortly. However, spiritual concerns also often arise, particularly among ethnic minorities. Some of these include confronting personal vulnerability and mortality, having religious or spiritual doubts, for example, doubting one's former belief in one's higher power or the teachings of one's faith. Perhaps feeling abandoned by or judged by one's religious or spiritual community. Religious and spiritual transformation can, of course, be a positive thing when an illness offers avenues for spiritual growth. But it may also include feelings of abandonment or punishment by God or one's higher power, feeling anger at God, feeling that one's religious path no longer fits. And religious or spiritual despair or distress is the feeling like life no longer holds meaning, and associated feelings include feelings of powerlessness, helplessness, regret, and disappointment. And this sounds very much like clinical depression, doesn't it? In fact, I think that the two of these are often present together. So dealing with advancing illness and one's own impending death is undoubtedly one of the most challenging experiences we can face as human beings. And the experience can cause great existential suffering on one hand, but it can also be a source and a time of great personal healing and evolution on the other. So what a privilege we have as oncology professionals to serve as witnesses and companions to our clients through these passages. Henri Nouwen observed, "Joy is hidden in compassion." The word compassion literally means to suffer with. It seems quite unlikely that suffering with another person would bring joy. Yet being with a person in pain, offering simple presence to someone in despair, sharing with a friend in times of confusion and uncertainty, such experiences can bring us joy, not happiness, not excitement, but the quiet joy of being there for someone else and living in deep solidarity with our brothers and sisters in this human family. Often this is a solidarity in weakness, in brokenness, in woundedness, but it leads us to the center of joy, which is sharing our humanity with others. I'd like to invite you to take a minute right now to reflect on whether this resonates for you. I'm going to read you the passage again in a moment, but first I would just ask you to put your pens or your phones down, perhaps push away from your desk a little bit, settle back into your chairs, and turn within for a moment. You can close your eyes if you'd like to, or allow your gaze to become soft and unfocused. Take a couple of long, slow, deep breaths in, exhaling any need to rush, just allowing yourself to be present in this moment. And as I read these words about compassion to you, allow some images or memories to simply arise of a time when you were present to a client, a colleague, or another being in need. Joy is hidden in compassion. The word compassion literally means to suffer with. It seems quite unlikely that suffering with another person would bring joy. Yet being with a person in pain, offering simple presence to someone in despair, sharing with a friend in times of confusion and uncertainty, such experiences can bring us deep joy, not happiness, not excitement, but the quiet joy of being there for someone else and living in deep solidarity with our brothers and sisters in this human family. Often this is a solidarity in weakness, in brokenness, in woundedness, but it leads us to the center of joy, which is sharing our humanity with others. Okay, please feel free to open your eyes again, stretch a bit if you'd like, and just come fully back into the now. And I'll suggest that it may be worthwhile to journal about this later as a way to reattune to these feelings of connection and compassion that you've experienced in your work. So we're going to turn in a moment to some of the interventions that may be particularly applicable in our work with people who have advanced cancer. And as we discuss these, I'd invite you to consider how they might also apply not only in your work with clients, but in your own work with yourself, both personally and professionally. Because along with the joy and fulfillment and opportunities for growth, we also experience our own stormy seas as professionals doing this work. We're in the presence of suffering a lot. And of course, much of our work is all about endeavoring to alleviate the suffering of others. Not only the suffering of our clients and their loved ones, but also the suffering of our colleagues, other members of our interdisciplinary teams. And there's a growing body of research on compassion fatigue and burnout. I also personally appreciate the way that Roshi Joan Halifax conceptualizes this type of professional distress that those of us who work in the field of end-of-life care as edge states. And she uses that term very deliberately in place of the term compassion fatigue. I'm sure that many of you are familiar with Roshi Joan Halifax and her work, but in case not, I have to give her a plug because she has significant credibility and is a wise and inspiring teacher. She has her PhD in medical anthropology. She's a Buddhist teacher, a writer, and a true pioneer in the field of end-of-life care. She's received fellowships from both the National Science Foundation and Harvard University, and she was a distinguished visiting scholar at the Library of Congress, where she really focused her research specifically on these edge states. And while I don't have time to go into great depth, if you're interested in becoming more familiar with her work and with this topic, I'd really encourage you to check out the references on her and possibly to look her up as well on YouTube, where you're going to be able to view some of her talks. But very briefly, Halifax described what is often called as compassion fatigue as secondary trauma, empathic distress, which is where we experience personal distress in the face of another being's suffering. Moral distress, outrage, and futility. And this is when we as caregivers know what needs to be done, but we can't actualize it. And as we all well know, this is something that we experience every day in our personal lives too, when we're exposed to horrific events happening all over the globe, events that we have no control over. But there is a cumulative effect to them. Pathological altruism is altruism in excess, where the individual who's caring can actually be harmed physically, psychologically, and emotionally by the act of caregiving, and that gives rise to a number of other edge states, including vital exhaustion or burnout, which refers to the experience of cumulative effects of excessive stress and excessive work demands, which occur when an individual, whether they're working for a healthcare system, a social service agency, a university, or any other kind of organization, really, when they're not able to establish appropriate boundaries with the institution for whom they're working. And as a result of that, they become depleted. I'm sure that nobody watching this can relate at all. But despite the stormy seas of this work, we have a lot of options and opportunities to anchor ourselves. None of these above states are a given, although it's important to be aware that we are at risk for them by virtue of the work that we do. However, right alongside the research that shows that caregiving can deplete us, there is also ample research that shows how caregiving can enhance our resilience. And I believe that the following interventions, among others, offer a lot of promise in this regard. Before we delve into these interventions, I want to highlight the common thread, which is that they all address, to some extent, the spiritual dimension of the human experience. So I'd like to offer a working definition of spirituality for our purposes and share some of the research findings regarding the importance of recognizing and addressing spirituality in our work with advanced cancer patients. Lever wrote that spirituality is the way in which people understand their lives in view of their ultimate meaning and value. Spirituality is one's sense of connectedness with oneself, with others, with nature, and with the transcendent. Spirituality is a universal concept found in all cultures, considered to encompass search for existential and ultimate meaning through religion or other paths. I also like the definition offered by the Consensus Conference on Improving Spiritual Care as a Dimension of Palliative Care, which described it as the aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to themselves, to others, to nature, and to the significant or the sacred. So please notice that the word meaning is a word that runs throughout these definitions. There's been a fair amount of research on spiritual well-being and its impact on quality of life and other health outcomes in recent years. And research has shown that in comparison to patients with advanced illness who report lower levels of spiritual well-being, those who report higher levels of spiritual well-being experience a reduction in anxiety, experience a reduced sense of isolation. They have a greater ability to tolerate severe physical symptoms, including pain. They report higher satisfaction with their quality of life. They have decreased feelings of despair, of hopelessness, and desire for death, independent from the variable of depression. And they do have decreased rates of clinical depression as well. Research has also demonstrated that robust, appropriate spiritual care delivered to those with advanced cancer results in earlier referral to and greater utilization of hospice care, less aggressive care measures at end of life, and I've starred that because I realize that that does reflect some bias in value, and that it results in better patient quality of life near death. So let's spend our remaining time talking about some of those interventions. I know that there's not going to be enough time today to go into great depth, so I would encourage you to explore some of the selections on the reference list and to look into both webcasts and live conferences where you can learn more. We're going to start with mindfulness. And we all know that mindfulness has gone viral, as this issue of the Psychotherapy Networker pointed out. I really love the subtitle, which is, "What Would Buddha Say?" But as we all know, mindfulness is not a new concept. It's been in practice for literally thousands of years, but we in the West are fairly Johnny-come-latelys. In terms of our work in the field of oncology, there's a growing body of work investigating the effects of mindfulness. And the research demonstrates that there are improvements in a range of outcomes, and including and especially quality of life domains, such as emotional, social, role, and physical functioning, and psychological improvements on measures including stress symptoms, anxiety, depression, fear, and avoidance, along with improvement in cancer-related symptoms such as fatigue, pain, and insomnia. Enhanced positive psychological constructs include developing the perception of post-traumatic growth and a deeper sense of spirituality. And just to take a step back for a moment, let's talk about what mindfulness is. Mindfulness has been very simply defined as a state of active, open attention on the present. And another way of saying it that I really like is the gentle effort to be continuously present with experience. When we're mindful, we observe our thoughts and feelings without judging, letting go of the concepts and labels of good and bad, right and wrong, functional and dysfunctional. Mindfulness is also about being present in life as it's unfolding and applying the attitudes of acceptance, non-judgment, patience, and openness or curiosity, along with non-judgment. I think we as social workers and our friends in chaplaincy are trained and often naturally inclined to offer these attitudes to our clients. But many of us sometimes struggle to offer these attitudes toward ourselves and sometimes to our other team members as well. So we and our clients and the majority of other human beings really spend a lot of our mental energy being anywhere but in the present moment in our minds. We're often worrying about the future, dwelling in the past, rehearsing or rehashing conversations, mentally bracing ourselves for difficulty, etc. You know the drill. And to bring this back to our work with people who have advanced cancer, we know that a normal human response to distress of any kind is to try to escape it somehow. We suppress painful thoughts and feelings, we distract ourselves, we numb out, etc. But we should ask ourselves, do these efforts at escape truly serve us? Let's try an illustration. Ever seen one of these? To use them, and they're often used as a gag or a prank, to use them, you have someone insert their index fingers at either end and then try pulling them out. And you can see what happens. Attempting to pull both your fingers out from the tube tightens the grip of it. In order to release the grip, you have to push in. It's counterintuitive, isn't it? Pushing in creates some freedom and some room to move around. So that's something to chew on a bit. And lest I be credited with this little nugget of clinical brilliance, I want you to know that this is an exercise that is often used in acceptance and commitment therapy and was developed by somebody who's much more clever than I am. But the point is that an alternative to futile attempts to escape distress is to attend and befriend, to push in, to bring the light of awareness to a feeling, no matter how uncomfortable it is, and offer oneself compassion. And also to recognize the temporary nature of feelings. They rise and they pass quite quickly, unless we begin creating a story around them with our thoughts. And this all sounds so simple, of course, but we know that it isn't, that it takes a lot of practice to remain awake, mindful, and compassionate toward ourselves. But it is a practice that can be developed and is well worth developing. One very simple but profound mindfulness exercise that we can teach to our clients and can also use ourselves when we're feeling distressed is based on a teaching by Thich Nhat Hanh, the Vietnamese Buddhist monk, and it's offered in the excellent book by Roshi Joan Halifax, Being with Dying, Cultivating Compassion and Fearlessness in the Presence of Death. And you can try this exercise out right now if you'd like. Once again, I'm going to invite you to put your pens down, move away from your desk a little bit, and just focus in on your breath, allowing the breath to carry you inward. Perhaps allowing your eyes to close again or your gaze to become soft and unfocused. And when you inhale, say to yourself, breathing in, I calm body and mind. And then as you exhale, you might say, breathing out, I let go. With the next inhalation, dwelling in the present moment. And as you exhale, this is the only moment. Once again, breathing in, I calm body and mind. Breathing out, I let go. Dwelling in the present moment. This is the only moment. Breathing in, calm. Breathing out, letting go. Present moment, only moment. And another even simpler version taught by Thich Nhat Hanh is breathing in, I breathe in peace. Breathing out, I smile. And practicing this for even 2 or 3 minutes a day can have a pretty profound effect. Many of my counseling clients have found this a very helpful way to calm down and to anchor themselves when they're feeling anxious. I'd like to turn now to Viktor Frankl, whom I know many of you are familiar with. Frankl was a Holocaust survivor who labored in 4 different concentration camps, including Auschwitz, during the war in Nazi Germany. His entire family, including his mother, his father, his brother, and his pregnant wife, were all murdered during the war in the camps. Frankl survived, and he went on to become a neurologist, a psychologist, and the founder of logotherapy and existential analysis. He probably studied and wrote more about meaning and purpose than any other 20th century thinker, and his book, Man's Search for Meaning, is still in print nearly 60 years after it was published, and is available, I believe, in 9 languages, and over 10 million copies have sold. Well worth the read. Frankl believed that those who have a why to live can bear almost any how. Those who have a why to live can bear almost any how. And he held that our primary drive in life is not pleasure, as Freudian theory posited, but the discovery and pursuit of what we personally find meaningful. So Frankl contributed incredibly rich ideas related to the spiritual dimension of the human experience, and specifically to what leads to authenticity and resilience despite the trials and challenges that life brings. Frankl's concepts related to meaning include the assertion that life is full of meaning, and it never ceases to have meaning, though meaning is both individual and contextual. What matters most to you may be very different from what matters most to me, of course. And what was most meaningful to you in childhood and adolescence and early adulthood may be very different from what is meaningful to you in middle and later adulthood. Again, Frankl asserted that the desire to find meaning is a primary drive. We humans are meaning-making creatures. We're compelled to find and make meaning. And we have the freedom to find meaning and to choose our attitude in any given circumstance. We may not have choices about the obstacles and losses that we face in our lives, but we do always have choice over how we respond. Frankl described 4 main sources of meaning in life. Creativity, which is how we engage in life through our work, our hobbies, the causes that we're devoted to, and so forth. Experience, how we connect with life through relationships, through nature, art, love, humor. Attitude, the attitude that we take towards suffering in particular, how we meet life's challenges, how we meet life's limitations, and how we transcend our circumstances. History, our story, our personal legacy, what we've given and what we hope to leave behind. not materially, but in the impact that we've made on others, on the love that we leave behind. So it's not difficult to perceive how very applicable this is to our work, particularly to our work with people living with advanced illness, is it? Frankl's theory, known as logotherapy, which stems from the Greek word logos, which means meaning, holds, as I mentioned earlier, that our primary drive in life is the discovery and pursuit of what we personally find meaningful. Frankl said that logotherapy encourages people to become the agents, authors, and producers of their unfolding story of life, illness, and death. Frankl himself considered logotherapy a spiritually oriented approach to psychotherapy. One of the goals of logotherapy is to help inspire people to a state of self-transcendence, where we move beyond our own self-concerns and aspire to do something outside of and greater than ourselves, to become more than our suffering. Frankl primarily applied logotherapy to his work with depressed patients, but although it wasn't specifically designed for the treatment of patients with life-threatening illness, his concepts and techniques clearly have great application in our work, and they form the underpinnings of meaning-centered psychotherapy, which I'll be touching on shortly. So logotherapy is about helping people to connect or reconnect with a sense of meaning in their lives. And we can facilitate this in part through the use of open-ended questions or prompts that help people to reflect. And again, I'd encourage you not only to consider using these questions with your clients, but also to use them with yourself, and to consider using them as conversational prompts for those whom you love dearly. Makes for much richer conversation than what the weather was like today or the score of our latest favorite sports team, although those are important as well. Don't want to be impolite to you sports fans. But some of these questions may include things like, what brings life to your life now? What's most important to you at this time in your life? How have your values changed over the course of your lifetime? What are you most proud of? How would you especially like your family to know and remember you? What do you feel most grateful for at this time in your life? When in your life have you felt the most peaceful? What brings you a sense of peace now? What have you learned about love and loving during your life? How important are religious or spiritual beliefs in your life at this time? What's your favorite way to connect with a sense of the divine? How would you describe your philosophy for getting through the rough times and getting enjoyment out of life? When your life is over, what things are people going to miss most about you? So you can see how these questions can invite a person to dig deeper, which is usually where the treasure is. And something that I mentioned earlier that fits in with the logotherapy model is helping people to redefine their purpose in life when they're no longer able to perform some of the roles from which they derived a sense of purpose before they became sick. This is when we as clinicians can help people to remember that some of the most very important roles in life are not dependent on our physical health, though we may have to adjust some of the ways in which we fulfill them. For example, we might ask a client to consider what makes a good friend. And I'll ask you right now to reflect on that. Think about the qualities that help describe a good friend. I suspect that if asked, you'd mention things like kindness, trustworthiness, honesty, being accepting of one another's shortcomings, etc. All qualities that are not dependent upon health and stamina. And the same thing occurs if we ask this same question and create the same type of list with other roles, such as parent, whether to minor children or adult children, son, daughter, partner, spouse, person of faith, etc. You might also note that many of these qualities might match the ones that you'd list if asked, what kind of person do you aspire to be? Not what do you aspire to do, but how do you aspire to be? When I have this conversation with my clients, I'll ask them, does your illness prevent you from developing these qualities? And the answer in nearly all cases is no. In fact, it's possible that illness, which often pares down a lot of the busyness from a person's life, might actually lead us to having a new perspective on what matters most. We were very fortunate at the AOSW conference to have had Dr. William Breitbart at our conference to talk about meaning-centered psychotherapy and meaning-centered group psychotherapy. And I'm afraid that I'm about to do a grave disservice to an incredibly rich intervention by simply highlighting a few key pieces. But I'd strongly encourage you to look at some of his articles and his forthcoming books. And for those that are interested in learning more about this modality, there are some NCI-funded trainings being offered regularly at Memorial Sloan Kettering Cancer Center. In brief, meaning-centered psychotherapy is consistent with the tenets of logotherapy. The key organizing construct is meaning. It incorporates concepts of existential philosophy and psychotherapy, and I'll talk about this in a moment. It's a brief educational intervention, 7 weeks for individual, 8 weeks for group, using a blend of didactics, discussion, and experiential exercises that focus on finding and sustaining a sense of meaning in the context of advanced cancer. And research on the efficacy of this intervention with advanced cancer patients is very promising, demonstrating that there's improved quality of life, greater sense of spiritual well-being and a sense of meaning, as well as decreased anxiety, hopelessness, and desire for death among those living with advanced cancer. According to Paul Wong, a researcher who's done a lot of work with meaning-centered psychotherapy, the main difference between logotherapy and meaning-centered counseling is that the former takes a philosophical and spiritual approach, whereas the latter favors a cognitive or psychological approach. But there are certainly very strong elements of the spiritual and existential in meaning-centered psychotherapy and meaning-centered group psychotherapy. Some of these underlying existential concepts include, as I've mentioned before when talking about Viktor Frankl, freedom and responsibility, choice, creativity, transformation and transcendence, authenticity, existential guilt, which results when the drive toward meaning is ignored or thwarted, and being unto death, recognizing that our beinghood, our lives are finite, and confronting this reality is essential to living an authentic life. In fact, in many monastic traditions, a skull is kept on the desk in order to keep the principle of being unto death, maintaining awareness that time is limited, and using that awareness not to frighten us, but to animate us and to inspire us to give our lives to that which truly matters. In Dr. Breitbart's words, existential therapy explores what it means to be human in light of our shared human condition. That is, we may live infinite possibilities, but we are essentially finite creatures. So in the last few minutes, I'd like to give you a little taste of this meaning-centered work. And because I've hoped to make the point that in addition to being an evidence-based, very beneficial intervention for clients with advanced cancer, these mindful and meaning-centered interventions can also help us as professionals to build our own personal and professional resiliency, to be authentic, to transcend our own suffering. So I would ask you to take some time to reflect on this question, these questions. What brings life to my work life now? Where are the places of deep meaning? And you may want to do some journaling on those questions. What I'd like to do is read you the response to these questions from two of our colleagues. Leora Lowenthal, the senior clinical social worker at Beth Israel Deaconess Medical Center, or I should say a senior clinical social worker, she's not the only one, responds, "What brings life to my work?" The patients and caregivers themselves. When thinking about the formal education that guides us in this profession, one may imagine that this work is straightforward and even predictable. The reality is that as soon as an actual person is introduced, nothing seems neat or simple. To help someone through the experience of cancer, one must be willing to dive in past the academic theories and texts and listen to the individual narrative. One must be willing to risk caring about the other person, share in triumphs and disappointments, feel fear, and sometimes even grieve. That is the reward of this work and also the price. And Melissa Stewart, senior clinical social worker at Memorial Sloan Kettering Cancer Center, responds, "I know that it is essential for me to keep growing and expanding as a professional and as a person in order to connect deeply and authentically in my work with people challenged by serious illness. Through ongoing study and personal exploration, I have attempted to become more open-hearted and less confined by my role and the idea that I am in some way safe or less vulnerable than my patients in regards to encountering despair, physical illness, or death. The places of deep meaning and life are the ones in which I am truly present to both the pain and the magnificence of the person with whom I sit. In those moments, I feel truly connected and alive. My role as witness, as guide and counselor is one that I honor as sacred." So I can think of no better words to close with. I'd like to reread two of those sentences to you again. "The places of deep meaning and life are the ones in which I am fully present to both the pain and the magnificence of the person with whom I sit. In those moments, I feel truly connected and alive." May you recognize your own resilience, your own transcendence, your own magnificence, and most importantly, your own humanity. Thank you.